I think we're ready to get started. So welcome, everybody. We're thrilled to have the opportunity to talk with you all. The topic of our panel today is the future of non-binary, how technology and culture can make health more human. I think it's a great topic. We got an amazing panel here to talk about it, and we're going to do some quick introductions.
Hi, my name is M.Ed Ralston, and I am the founder and CEO of Non-Binary Solutions. My pronouns are she, her, and sometimes y'all, since I'm out of Lexington, Kentucky. I've been a 25-year clinician and expert in autism and now neurodiversity. I built 2 clinics in Kentucky, and I sold the last one to the 4th largest provider agency in the U.S. in 2019. And then I started Non-Binary Solutions, where we're making clinical decision co-pilot software for other constituents of autism and neurodiverse outcomes.
I'm Jamie, after that impressive introduction. I haven't sold 2 clinics, but I am a pulmonary critical care physician in Southern California, and my specialty is within immunology as it pertains to the lung, and I do a lot of medical production.
And my name is Oodaye Shukla. I'm Chief AI Analytics and Data Officer at Havas. So my background is signals analysis, and AI.
All right, so we got a really diverse panel, set of expertise, given how unique and diverse the topic is. So we're in the midst of the greatest period of innovation in health. At the same time, the way people relate to their gender is also advancing. Both science and people have become more complex, and the way we approach healthcare is not keeping pace with these changes. People are feeling marginalized, health outcomes, and overall quality of care are suffering, and the issues will only become more severe with time. To put a data point against this, 41% of non-binary adults report poor health. Amongst that, 64% worry about negative judgment and being treated poorly by the healthcare system. So let's start the conversation. So when we think about non-binary, Mandy, how do you think about the terminology and the lexicon there?
Yeah, so non-binary, of course, we're talking about gender on one level, but that's the idea. Generally, binary thinking is the notion that there are only 2 sides to some issue, and that you have to pick one, right? So it's dichotomous thinking, right? You get a false dichotomy when somebody forces you into making a choice between this or that. Part of the reason that I named my company Non-Binary Solutions is because in order to treat people properly as a clinician or a healthcare provider, people are not black and white, right? They are shades of gray. And so to actually treat them in their full holistic humanity, you have to see the full spectrum of their being, right? Secondly, the reason I named the company Non-Binary Solutions is because I get to say in groups of people like this now, did you know that people on the autism spectrum are 6 times more likely to not identify with the gender they were assigned at birth, right? So now if you care about individuals with autism or neurodiversity, you also now have to care about non-binary, transgender, transfluid people.
All right. Jamie, in terms of the healthcare system, I mean, how do you think that relates? Are they thinking about it in a similar way?
I do think about it in a similar way, but I think from a healthcare perspective, it's clear that a lot of physicians are not comfortable caring for that group, and the population actually feels this, right? They feel like they're not cared for. They will not go to certain places. They won't go to certain clinics. They won't show themselves because they're afraid of being judged, and I think that that's a huge issue. And so I do think that, as Mandy has stated, we have to be more non-binary, because when you actually look at medicine as a whole, or even disease as a whole, disease is just as gray. Like, disease is gray. And so we have to be able to spend the time talking to people, understanding where they're coming from, so that we can better understand their environment, which is really what impacts their risk of developing certain conditions.
And just to unpack that a little bit more, I mean, what do you think the basis for that biased behavior, or that myopic behavior, if you will?
It's not learned. And in medical school and residency and fellowship, you're taught certain disease. You're taught pathophysiology. One of the biggest lessons of medicine is learning how to communicate it, which is what I spent a lot of time on. But physicians aren't taught how to communicate it. And so when you're going through that path as a learner, you receive all of this information and you apply all the information that you receive we're just not receiving that teaching. We're not receiving that information. We're not receiving how to define it. We're not receiving how to speak to these individuals. We're not receiving how to, they don't even receive how to speak to people that look like me. I mean, most physicians are white. They don't know how to speak to black people. Like, so I think that we have to learn these things, and we really have to be intentional with our teaching process. And as we do that, we will be better, but we just haven't done it yet.
Yeah, I mean, dichotomous thinking and binary thinking is taught from childhood. Like, this is rooted into our education system, right? We're taught true or false. There's multiple choice questions. There's only one right answer, right? Everything is categorized quickly into man, woman, boy, girl, male, female, all of it. And so we're taught to think in a binary way, and then we get comfortable with that. Because the other end of the spectrum in decision-making is the paradox of choice. Like, if you're familiar with going into a grocery store and seeing the yogurt aisle, like, there's a yogurt aisle. There's that much yogurt in the world. You're suddenly faced with a choice about what yogurt to eat, right? That's the other end. So binary thinking is sort of this quick way of moving through the world that you categorize everything as this or that, right? But the problem is, once you stop actively making choices about those binaries, then it becomes bias, right? Then it's operating on your hard drive, and it's just there.
So all four of us reside in the U.S. Where does the U.S. sit relative to the rest of the world in this thinking around non-binary?
Well, I think that Western civilization needs to catch up to some of the other South Asia and indigenous cultures that have understood for a long time that there are more than two genders, right? Indigenous folks talk about two spirits, right? And you go to some of the South Asia groups, and they already have 5 categories for gender rather than just 2. And, the data is in the healthcare data as well, that we know that people are not just on a XX or an XY, right? So I think that we need to use that data to actually educate the public rather than the public dictating legislation in the U.S. as it goes for individuals that are on a non-binary spectrum.
Now, treatment disparities in healthcare is nothing new. We've known about this for a really, really long time, particularly minorities and women. So, Mandy, as you think about like some examples around minorities and women, like what comes to mind in terms of treatment disparities?
Again, from a U.S. perspective, I can't watch TV without seeing a commercial for Peyronie's disease or erectile dysfunction, and yet we don't have answers to basic things like menopause or endometriosis. So women, first and foremost, large disparity there. If you talk about the rate of mortality for black women in childbirth versus white women in childbirth, it's 6 times more likely, right? Huge disparity there. So, I could go on. Jamie?
Just to share a quick story about my family, to add some context to this. My grandmother, who died at the age of 95, awesome woman, wrote over 40 books. She had a thyroid goiter when she was about 26, 27 years old. Grew up in the South, lived in the South, couldn't get care for the goiter. Nobody would treat it. Went from doctor to doctor. They finally found a back alley surgeon to do the surgery, right? Because she had to go to a black hospital and get the surgery done. They didn't have the appropriate support staff, the appropriate equipment. When they did the surgery, they actually cut her recurrent laryngeal nerve. Now, the recurrent laryngeal nerve is a nerve that innervates your voice box. So it closes your vocal cords, opens your vocal cords. She couldn't breathe after she got the surgery. And when she was pregnant with twins, with my mom and her sister, she was having trouble breathing, so they put a tracheostomy in. She kept the tracheostomy her entire life, and it was completely uncared for her entire life. No medical provider cared for it. She cared for it on her own. And it's probably what drove me to become a pulmonologist. But when I think about that example of, discrimination or lack of access or lack of care, she was a minority female, which is probably, the worst group that's cared for, and we have literature to support this, is transgender minority individuals, right? So she was a minority female that wasn't cared for, and I imagine what transgender, gender-neutral individuals go through now, today. And this is, 100 years later.
Now, data is a big foundation for a lot of this thinking, particularly in the healthcare system. The data that's generated to support regulatory approval of the products, it's the basis for how the healthcare professionals understand the products, how healthcare systems adopt them. So, Oodaye, where is the data falling down in today's environment?
So, there's a lot of healthcare data out there. in the US, they have data on 320 million people going back to 2014 based on the High-Tech Act that was passed in 2012 or so. They're collecting a lot of data. The biggest, and in Europe, there's something called the Health Improvement Network. And with that, they have 72 million people across EU5, and including the UK and Belgium and Romania. So there's a lot of data out there. The issue becomes, is it purposefully collected? It is, what is the purpose of the data? How is it collected, and what is it used for? In the US, it's claims data. So claims data is you go into a doctor, he provides some service to you, he fills out an insurance claim form, and he wants to get paid, or she wants to get paid. Now, the intent of that data submission is to get paid. In Europe, the intent of that diagnosis and collecting the data is to get diagnosed. So inherently, in the US, you have a couple biases. A, does somebody have healthcare insurance? That inherently is a bias. If you don't have healthcare insurance, you're not going to go to an insurance company. Your claim is not going to go to an insurance company, and they won't collect that data. By the way, in the US, what they do is once they collect that data, they anonymize it and sell it to aggregators. So everything in the US is for sale. That we know. Now, because of the way it's collected and then from the purpose it's collected, that data is inherently biased. So there's upcoding. Doctors always code to get paid, not necessarily to diagnose. So inherently, we have to look at that data with that lens. So whenever we do analysis, claims analysis, we make sure, okay, what is the demographic? Does it match the census? Are we missing a group? Why is the coding this way? Just because a code has a description doesn't mean that's the way it is being used. It is being used that way for reimbursement. So we have to kind of understand the subtleties of the data, why it's collected, and for what purpose.
We also code to get care for people too. not just to get paid.
But Jamie, you bring up a point because, I mean, it's been well documented that healthcare professionals sometimes work the system to rationalize and justify the care for people, given a lot of these situations. Has that been your experience?
I'm basically an autoimmune disease pulmonologist, and so autoimmune disease inherently is gray, right? And so we have these certain qualifications of certain illnesses and say, okay, if you have these 5 things, you have this autoimmune disease. But what if a patient has 4 and they don't have 5, right? But they got 4 of the qualities. Well, then I'm going to, I guess you could say, fudge the data, but it's not fudging the data. It's giving the patient the diagnosis that's going to allow them to receive the best care.
Correct.
Right? And so that's what I'm trying to do. And I get how difficult and how maybe biased at times that can be. But when you're thinking about the immune system is happening to us all right now. Every breath that you take, your cells in your lung are constantly exposed to the environment. And these immune cells are moving in your body based on what they're exposed to. And just because I take a quick picture in clinic doesn't mean that it stops happening once you leave my door. It's continuing to happen. So when you think of autoimmune disease, you have to understand this process that's continuing to take place, and you have to have this in your mind and understand where the patient is going, not where the patient is right now, because your job is to prevent disease, right? It's to prevent illness. It's to prevent people from being in the hospital. And so you have to have a little bit of foresight. And at times, the payers or whoever, they don't allow us that foresight. They're kind of forcing us to make that decision, which is what we were talking about earlier.
Right. And, as we all know, we are in the midst of one of the most significant scientific periods of scientific advancement that's happening. More data, more innovation from a healthcare perspective than we ever seen, and it's only accelerating at this point. So a lot of what we're discussing only becomes magnified, right? Like bad data building on bad data, building on bad data. And, we can't have a panel conversation without talking about AI. So let's talk for a moment about AI. Oodaye, like what role is AI playing in innovation in health?
So AI, the latest innovation of AI is generative pre-trained transformers, or GPTs. So the difference is from prior innovations in machine learning and AI is that it generates content. It is able to ingest and summarize a lot of documents. It's based on natural language. So one of the real key differences is that you can converse with your data in natural language. You don't have to have a data science degree or learn programming. That's a real key. So given that innovation, it holds the potential of being able to ingest a lot of scientific content and to reason and to create new content. Now, the key is, and as you've seen in the press and the media, there have been real instances of bias in these models. Some of these biases have been a bit embarrassing for large companies. And the reason is that is the training data that they've used. Today, training data is gold. You have to be able to create really unbiased, valued, purposeful training data to train your large language models. Then they become useful. So that's the key, is to being able to get data that is collected purposefully, unbiased, and then train your large language models.
I saw something interesting, if not amusing or terrifying, on the internet yesterday, and it's that Meta had an advisory council for their AI that was completely comprised of white men. Like, no persons of color, no women, all white men, to train the data related to what the AI is going to be learning so that we might avoid bias. Okay.
Where do we go from that? I don't know where we go from that. That's a mic drop moment. So when we think about all the limitations and defects with the data today, I mean, how do we think about course correcting? How do we think about getting things on the right path?
So like I mentioned before, it has to be purposeful. You have to be able to represent every demographic. That data has to be curated and reviewed. So it can't be we download everything off the internet and train a model and release it, or have non-representation on what the ethics of that large language model will do. Now, currently you have MedPalm 1, MedPalm 2 from Google, and they do really well. I mean, they're very accurate across different specialties and different sub-areas of medicine, but they're not good across all. So there has to be a concerted effort or an independent body to be able to review these large language models, understand what they call the data pile that's being used to train these models. And when you deploy these models, how are they being deployed? What's the feedback? And what is the ongoing performance?
And Jamie, from a healthcare professional physician standpoint, right? And you think about the challenges with the data that physicians are referencing and all of that. I mean, what's your feeling in terms of optimism about their ability to shift and change? Because with all more data coming in, it's sort of in a way compounding the problem.
Yeah, physicians feel, a little overwhelmed right now, right? Because they're getting all of this information and they don't quite know what to do with it. I mean, from my perspective, the goal was to eat, so I don't mind the full plate. But again, when I'm thinking about the way that I think about society this day, it's not really information overload. It's really more of a problem with filter. It's filter failure. And so for me, the way I look at AI is, AI would be an excellent way of being able to filter this information so that we can understand this information and then apply what we learn from that, right, in caring for different individuals of different groups, right, of different ethnic groups, of different socioeconomic status groups, of different groups in general, because I think that's really the important thing for me is the environment with which these groups are present is really how it's going to affect their condition. So I think that AI is going to be extremely helpful if we can sift through the bias that's going to exist because of the white guys on the Meta panel.
And it's not inconceivable in the near future to have a large language model to be an assistant and to be unbiased and to be trained properly and to be certified. And that's in the realm of possibility. It's not undoable. It's something if we're purposeful and focused, then that's something we can do very quickly.
Yeah, I mean, that's part of what we're trying to do at Non-Binary Solutions with our software, noetic.ai. We are standardizing the intake process and understanding who all these very different people with autism are coming into care, right? Because I can go off on this one if you want me to.
Ahead.
Okay. So autism
Did I even have a say in that?
No, not really. Yeah, I'll just keep going here. So autism is viewed often as a monolith, right? But if I take you through sort of the timeline of what's happened in the last 40 years for autism, starting in 1980, the DSM-3 came out, and that is the first time in history that autism and childhood schizophrenia are differentiated as a diagnosis, right? So at that point, it's 1 in every 10,000 individuals are diagnosed with autism. Flash forward, you get to 1994. That's when the DSM-4 comes out. Now you've got autism, Asperger's syndrome, childhood disintegrative disorder, not PDD, NOS, which is pervasive developmental disorder not otherwise specified, and Rett's disorder, right? So you've got 5 different diagnoses now, right? And we also have 3% of Americans have now tried something called the World Wide Web in 1994, right? So now you've got 5 different diagnoses, and then by 2000, 78% of Americans have now downloaded music, right? So in 5 years of time, look how fast of a rate of adoption for a technology we had, right? And during that time, the rate of autism went from 1 in every 1,000 to 1 in 125, right? So the parents were starting to find each other, right? They're sharing information, they're understanding, hey, that sounds like my kid. How did you get this treatment over here? What is this treatment you're doing called? It's applied behavior analysis. Hey, Indiana just passed an insurance mandate in 2001. How did they get an insurance mandate that now covers all these services? And in 1998, the Behavior Analyst Certification Board is started. So when I got certified originally in 2002, I was one of the first 1,500 board-certified behavior analysts worldwide, right? By the time you get to 2018, you've got 48,000 behavior analysts worldwide. That's it. And the rate of autism is now 1 in every 36. And there is a mandated insurance coverage in all 50 states, right? So that flywheel of information and sharing and understanding of what autism is, by the time you get to 2012, also, they got rid of Asperger's, childhood disintegrative disorder, and all those other diagnoses, and they put everybody into this one spectrum, one code, F84.0, which is autism spectrum disorder, right? So now if you talk about people with autism, you could be talking about somebody that cannot talk, will always need care for themselves for the rest of their lives, punches themselves in the face 100 times a day, and you could also be talking about the guy that gets called into HR because he's perceived as being rude. All of those people have autism, right? So reporting outcomes on that monolith is ridiculous. And so really understanding who's in the data and who actually benefits from what types of treatments, under what circumstances, and what settings, that's what the real job of AI and this data set is going to do.
So help me understand one thing, and Jamie, this may come to you, but I'm seeing things moving in different directions, what you described with autism, but we see in other areas of health and science, like oncology, for instance. Rather than oversimplifying things, things are getting incredibly diversified, very, very specialized to drive tailored, specialized treatment for each individual. Why, in some cases, do we have such a stratification and customization about the way we think? Because innovation is teaching us more about these diseases we've ever known. But then we have systems doing just what Mandy described.
What a heavy question. I find what Mandy just described strikingly similar to autoimmune disease, just because of the same kind of qualifications where you've got 2 opposite ends of the spectrum within the same group, which doesn't make any sense in terms of therapies. I think the reason why we're in this space is because we have so much more information that we haven't done anything with yet. We haven't filtered it yet. And when you look at medicine and the way medicine is studied, it's traditionally studied in clinical trials, right? And clinical trials are binary, yes, no, right? Black, white, right? Have this or don't. Well, yeah, mostly white, 98%. Have this or don't have this condition, right? Cough, yes, no. And I think that's why we're there. But the people who take care of individuals in that gray area, which is essentially almost everybody, the individuals that tend to think about this, the way that we get through our day is we simply code the way that things are going to be able to get paid for on our end and the patient's end, but we still think gray. When you read our notes have a paragraph of what the patient is going through and why the patient's going through this and what we believe, instead of being binary. And that's why I found this whole thing very fascinating, is because we are already there kind of clinically when we're taking care of individuals. We individually take care of people. And we do certain things. We don't just do the same thing because this person presented with sepsis or this person, we're going to do the same thing with everybody. We do it individually, and I think we're moving towards that. But I don't know. I mean, the payers have to move towards that too, and I think it becomes extraordinarily difficult because of the way it was already traditionally organized.
Right.
Yeah, and that brings up a good point of ambiguous coding. So when you have ambiguous coding, when you're trying to determine prevalence and incidence of a disease state, you have to bring in, well, okay, this code is very ambiguous. How would the provider use it? What are the patients that would fall into this category? So now you have to bring in procedure codes, you have to bring in drugs, you have to build a constellation of codes around this patient pool to kind of identify who that patient is in the data. So this becomes much, much harder. Now, I know like organizations and companies can submit to have a code in the ICD-10 code list, but that takes time, that takes money, and that takes CMS. And they get updated every October. So, but there is a process.
So let's take this full circle now. Let's talk about like how we drive change, and our topic is how culture and technology can help to influence change. Let's start with culture, right? So from a consumer, a patient standpoint, a healthcare professional standpoint, I would say even a system standpoint, because like we've been discussing, if the business value, the business model isn't there, it's not going to work. So, Andy, what are your perspectives in terms of how we start shifting culture, start leveraging culture? Take a broad brush to that.
Yeah, I mean, generally speaking, again, it's really starting to look at the broad spectrum of the individuals that you're working with, rather than trying to treat people as a black or white situation. You really do need to see the gray in order to understand the humanity of the individuals that you're working with. Jamie, help me. I forgot where I was going with this one.
I'm just going to point to the pandemic because it's something I can point to that's pretty easy and everybody understands the reference point. During the pandemic, I had an opportunity to interview Fauci, Dr. Fauci, on one of my shows. And I'm interviewing him, I'm talking to him, and I said, hey, listen, I was like, Tony. He told me to call him Tony. I was like, Tony, listen. I was like, you had a year and a half to teach people the immunology of vaccination instead of telling people what to do. I said, why didn't you do it? And this is where I think all this starts. And he said, I don't know. I think I don't know are the three most powerful words in the English language. And the reason I think that is because it allows you to become aware of what you don't know, and it forces you to think about what the question actually is. Whereas if you're coming up with an answer, you're not even thinking about the question anymore because you have this answer.
That's right.
But when you say, I don't know, and I thought that his answer was excellent. When you say, I don't know, like he said, you know what? We needed to communicate better. You have to teach immunology. Because I think for me, if you teach the foundation with which the concept is that you're trying to get across, which is you want people to get vaccinated, for example, then they get to make their own decision based on the education that they have received now. And so I think this is going to, at least from a medicine perspective, for me, disease is how the immune system responds to the environment. So you have to teach about the immune system first to get people to understand how autoimmune disease works, and then you can start to implement some of this change. But I think it starts with a complete foundational shift. Everything that we do today has been defined by things 50, 60, 70 years ago. That shit is wrong. Like, we have to break that down, and we got to restart and build it up with the information that we have today. That, I think, is the first thing to do. But it just requires a lot of individuals who have a lot more experience maybe than we do to kind of swallow their pride and say, oh, I didn't know this 70 years ago. I get it. You were great. I'm glad you did this. Then it was excellent. But now it's wrong. So let's restart this. And that, for some reason, is a difficult pill to swallow for people.
Yeah, I thought of a quote. Mark Twain said, it ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so, right? So it's all the data and assumptions that you've been working off of that are no longer true that is going to be problematic in your decision-making day to day. And that's why I think technology is very important to healthcare at this point, because it can actually move you past the stubborn quo, the bias that you've been working in for a long time, right? And actually bring you the new data immediately as to what is actually effective. Right? It's like in behavior analysis, there was a study about, do the traffic signs that flash your speed slow you down? And when you interview people and you ask them, do those signs actually slow you down? They said, no, they don't really actually change my behavior, but the data shows that it actually does. Right? And so that's the power of technology, is to say, here's actually a better way of doing things. Have you thought about this wider spectrum of possibilities in treatment so that you're just not going back to your old bag of tricks that you use over and over and over again that you've been doing since you got out of school, right?
In asthma, and I do a lot of work with Allison and the team in asthma, the way that we measure lung function is you breathe in a box. You take a big breath in, you blow air out, we measure how much volume of air comes out of your lung. Really simple. To understand the average of how much air comes out of your lung, people measured this in different cultures 400 years ago. So in African Americans where we were working in the fields and exposed to all kinds of chemicals that we breathe in, we all had asthma, we all had interstitial lung disease, our lungs appeared smaller. So they actually programmed that into the system. So on average, since our lungs are smaller, we're allowed to have more disease than the typical heterosexual white male, right? So in other words, we're getting treated way later than other individuals because of when our lung function was measured 400 years ago. Now, do black people have smaller lungs than white people? No, our lungs are the same, right? But there are individuals that don't know that and don't think about that. So you have to create an awareness campaign. And finally, after hundreds of years, the American Thoracic Society finally said, hey, don't do that anymore, like a month ago. Duh. Like, right? Like, it doesn't. So these are the kinds of things that we have to do. But for some reason, for us to be able to garner enough awareness and attention to do this, it takes, like, you have to move heaven and hell before you can actually get to that point. And I'm just talking about one test. Can you imagine doing this across the entire spectrum of healthcare?
So great example. So when we think, again, more data coming in, this isn't like we got to fix this with the train going down the tracks or the jet really in the air. From a tech standpoint, how is that? That's got to be a big part of the solution, right, Oodaye?
And like you said before, more data is not good data. Doesn't mean good data.
Right.
Like you just mentioned from the foundation. So I was just looking at Retraction Watch, and there are 46,000 scientific papers that have been retracted. And a lot of these papers are just paper mills. So you have to go back and look at the foundation and understand, is this paper valid? Is this scientific paper, which everybody has cited and refereed to, is it actually valid now? So we have to build everything from a foundation because there's an amplifying effect, like we mentioned before. And the technology and the large language models and AI will amplify that bias if not corrected. And that's what we have to watch out for.
Yeah, I mean, I think about people saying things and making assumptions about what's effective for autism treatment these days, and it's like we have the data. We have the data to show that kids can actually benefit from 20 hours a week of therapy rather than 48 hours a week. And I'm like, well, who's in that data, right? If we're just looking at insurance data, commercial insurance data, that's a very privileged group of people based on the fact that they have the financial background to afford that type of health plan, right? So it's not addressing the complete group of people that may also have that diagnosis, and that's true across healthcare.
Awesome. Well, why don't we open it up to any questions from the group? Anybody have any questions for the panel? All right. Mic drop. All right. Well, thank you very much, everybody. Really appreciate it. And thank you very much.
Beautiful people.
Thank you.